I don't know if we have time for a break. Okay. All right. Well, good afternoon, everybody. It's Frances here at Union Tract. I am very excited to be talking about something near and dear to my heart. For anyone that knows me, knows that I've been dealing with some knee issues. And through this, I would call it a journey, I've learned a ton. I've really dug into the research. And I think whenever it comes to, your own health and something that happened and making decisions, something as big as surgery, because I had never had surgery before. So I was terrified and I really wanted to know all of my options. So not going to make everyone into orthopedic specialists today. That's not my goal, but some of this stuff does get a little nitty gritty, but I want to keep it generalized. And there are a lot of themes that can relate to primary care, specifically like patient advocacy, and then new developments in research on really the power of the body to heal, and personalized medicine. So let's get started. So this is me doing what I love to do and wish I could do all the time. It's just a short gif of me bouldering, but on August 14th, this video doesn't capture my accident, but I was bouldering at a new gym in Wilmington when I fell about 8 feet from the wall and landed on a hyperextended right leg and twisted. Immediately felt pain. Immediately, my body just gave way and I could not bear weight. And I just knew something was wrong. And my first instinct was like, this is my ACL. I'm like, I didn't hear the pop, but it was loud. And I was like, I just knew it was my ACL. So I subsequently went to urgent care like 2 days after and was diagnosed with the ACL tear. They got the MRI and that confirmed it. And they immediately were like, okay, it's reconstruction surgery for you. And I went to see actually 3 different orthopedic surgeons. When I came across a new technique for ACL preservation, and you'll see this here where I'm holding the teddy bear. It comes really important later. And the journey so far, my surgery was actually on September 22nd. So it was about a month after my injury. And usually with traditional reconstruction, you wouldn't get it till maybe 3 months or so later after all the swelling really went down. And then, the rehab with crutches and the bracing and trying to keep my upper body level strength up still. But really just rehab has been essential. And we'll go over that a little bit as well. So let's go to the next slide.
Frances, if you're talking, you're muted.
Thank you. I'm so sorry. I don't know what happened there. Where did I leave off? Did y'all hear everything from this last slide? I don't know how I became muted. Oops.
Just on the objective slide. That was it.
Okay, we'll just start here then. So we'll just go over today kind of about how often this happens, how it happens, the anatomy, diagnosis, how is it treated, what is ACL repair, can it be repaired, what kind of patients do we consider repair on, and then we'll go into a little bit about prevention programs of rehab and how this can be applied to other type of ligament injuries. And then of note, no financial incentives to disclose. I wish I was making money, but I'm not. All right, so knee ACL injuries, you probably know somebody at some point, especially if you played sports in high school, of somebody who had torn their ACL or had to get surgery. It's quite common and one of the most common knee injuries that happens, requiring up to 100,000 surgeries a year. And as per our previous AFP articles, we all know female athletes are more prone to this. And especially those involved in higher level sports, such as involving twisting, landing, pivoting, gymnastics, basketball, football, skiing, soccer are most common. And these rates are actually trending upwards because more and more of our high schoolers and middle schoolers are participating in high level sports, and it's getting more competitive as well. So the ACL, there's some non-modifiable and modifiable risk factors like discussed before. Some of those non-modifiable ones being a female gender, having some previous injuries in your knees, also that higher level of competition. Some of our modifiable risk factors are things that have to do with strengthening and that neurodynamic control with our sense of knee, and then also with just whatever activity we're doing, making sure that we're doing it with correct form. So here, the ACL, arises from the anterior medial aspect of the intercondylar area on the tibial plateau, passes upwards and backwards to attach onto the posterior medial aspect of the lateral femoral condyle. And its main purpose is to stabilize the knee from shifting too much forward or backward on the tibia. And you can see the PCL is there as well and also contributes to that. And this is a little schematic of kind of an example of how it happens, which is kind of how it happened for me when I fell and landed. The anatomy of it and the ACL. So this was interesting to me because I really was like, oh, it's just another ligament in the body. But actually, it has its own blood and nerve supply. The blood supply are these branches of the medial genicular artery, and then the nerve supply comes off the tibial artery. It also appears that aside from its vasomotor function, they may serve a proprioceptive and sensory function, which comes into handy with those high-level sports and landing and jumping. So that was, I did not know that before going in. I thought it was just mostly stabilizing. It also is made up of two bundles, actually, which have different types of structure and help with different motions, such as the anterior medial one kind of helps with that posterior direction, and then the posterior lateral with the pivoting and twisting. This is just because mostly when someone tears their ACL, they tear through both, and a traditional reconstruction just puts one ligament through. It doesn't do like a double bundle type surgery. There are some new reconstructions that are considering that. So how do we diagnose a torn ACL? Someone comes to your office and they've been skiing or playing basketball, twisted their knee, heard a pop. They're in your office and it's really swollen. Well, the Lachman's test is actually what's more preferred. And this schematic teaches you how to do it. So you want to bend the knee 20 to 30 degrees, stabilize the femur with one hand, and pull the tibia anteriorly against the femur. The difficult thing about this test is it can only be done when the knee is not super swollen and inflamed, and the person may be in a lot of pain, especially if the tear was recent. So it can be really more of a clinical diagnosis because this test may be too much pain. When I went to see urgent care, it was maybe like 36 or so hours after, and they were able to do a full Lachman's on me, and they tested my other knee, which was significantly more stable, and they were like, it's definitely torn. So and the Lachman's test actually more diagnostic accuracy than the traditional anterior posterior that we've also been taught, the drawer test. The next step after clinical diagnosis is the MRI. So as you can see here, a normal ACL has these fibers running through that are very consistent. You can see it really, really well here. And a torn ACL, it's just going to look like mush inside there. And you can still see the PCL is very intact, but that ACL, you can't see those consistent fibers. So how is this treated? Well, conventionally, 9 times out of 10, the orthopedic doctor will say, you either need surgery or you don't need surgery. And this has to do a lot with different factors such as age, your activity level. Usually for someone who's young and very active and wants to participate in competitive sports, they will say yes to reconstruction. While if you're older and not as active, they may say that you might be okay just doing rehab without the surgery. This is Dr. DeFelice. He is actually one of the pioneers of ACL preservation and really honing in on what types of ACLs can be repaired, and why we are not trying to save the ACL more, especially if it's torn intact versus when it just ruptures. So he's a big prominent person doing all that, and it's like remarkable the amount of people's ACLs he's been able to preserve, and the outlook of his patients, not having to wait sometimes 9 months to a year to come back to play sports. Sometimes as short as 6 months, they feel back to normal, and they have that really good prognosis. So we'll go more into that. So what is a traditional ACL surgery? Well, they remove your native ACL completely, and this is all done arthroscopically. There are several graft options that they use whenever they take the ACL out, and this includes your autografts. So your patellar, which is very common, especially for high-level sports. Hamstring and quadriceps are other ones. The cadaver tendon can also be obtained, and that is usually for our older folks because it has a higher risk of re-tear for younger people. So it isn't really used that often for younger people. The procedure, it takes about an hour. You're put under general anesthesia. They do a really good nerve block. And possible complications are just for typical surgeries, clots, bleeding, infection, such. The patellar graft and the hamstring graft are probably the two most popular. The quadriceps graft is becoming more popular now, but it's newer in its technique. And the concept behind these grafts is once that tissue is taken out, your tendon kind of heals on its own. It has been shown that people's hamstrings have been somewhat weaker after getting a hamstring tendon. So there are some pitfalls to this. Reconstruction was invented in 1935, and it's been the gold standard since then because orthopedic surgeons tried to put the ACL back together in the past, and they would have a 50% failure rate. So when they started doing reconstruction, they saw like an 80% success rate, so it quickly caught on. But there are some pitfalls of this, especially doing a one-size-fits-all reconstruction for everybody. They need to make new tunnels in your bones to dictate where to try as much as they can. The most experienced surgeon will try to make it so that it's similar to your native tunnels, but almost can never really get it to be exact. And because of that, most people or pretty much everyone with an ACL reconstruction will have some amount of osteoarthritis about 15 or 20 years down the line. And that's still better than not getting reconstruction because that risk of osteoarthritis goes up even significantly more. So compared to not getting surgery for a younger person, surgery is still preferred for that reason, but we can do better. There are some new techniques now. The other thing is when they take out your graft and they put a new piece of graft in, it can be really strong and structural, but you kind of lose those proprioceptive and nerve cells. And that can be gained back through rehab, but people will say that their knee that just doesn't feel the same again after surgery. And with the grafts, you're kind of doing what's called burning bridges. So once you've taken a graft out of your hamstring, now you have 2 other grafts left. What happens if you tear it again? You can get it from the other grafts, but you're making those tunnels bigger. You're putting at risk of further surgeries. And the outlook of reconstruction after a tear, after it's already been reconstructed, it doesn't look great. A lot of people suffer with continued knee pain after that. And like we talked about, the hamstring strength. So those are the biggest pitfalls. So going back to does one size fits all? Does everyone who tears their ACL and is young, is athletic, wants to stay athletic, does not want osteoarthritis right away, should they get a reconstruction? And that's just the only thing we can do, right? But that's not true. So there is, even though there's an 80% success rate, there is still a 20% failure rate. And that usually happens younger people. And of course, those who are very active and are not really following post-op instructions. But also with our younger folks who may need to get back to competitive sports quicker. So what the research has shown, and this is a paper, Primary Repair, where they tested ACL repair versus reconstruction. And it wasn't a big sample size, but because there just isn't a lot of data for ACL repair. It's very much more common in Europe and Asia and other parts of the world. But they did see that for those who were good candidates for repair, the success rate was like above 95%, and that the failure rate was much less than with reconstruction. And that with rehab, some patients were going back and playing at 6 months or so, depending on what type of repair they got. And what types of tears did the study show were favored? Well, it was these proximal avulsions, meaning the ACL tore completely off the bone, and these proximal avulsions, which are proximal tears, which were really high up, close to the femur. These two types of tears are about maybe 20 to 30% of people that have ACL issues, and they can really benefit from a repair versus a reconstruction. So going more into this, so not all tears are the same. Like I said, you can have a proximal tear where it comes clean off, and this is actually how mine tore. It can tear completely in the middle. This is called a mid-substance tear, or it can tear distally. And then also it can tear either in one piece like this cleanly. It can split into two strands like those bundles we mentioned, or it can just completely rupture to where it's just looks like a chaos in your knee. And then there's also different grades as well. So why was ACL repair so quickly abandoned because of these 50% failure rates? Well, looking back, it has a lot to do with the fact that they were not selective on which patients they chose to do repairs on. So they were repairing everybody from the, the super destroyed, ruptured ACLs to your proximal ones. They were not being selective with their patient population. So that's probably why the failure rate was so high. And on top of this, the success rate was probably 50%. One of the landmark papers on ACL repair was this one done. It was back in 1989, but it talked about, even back then, how looking back into who was having success and who was having failures, they saw that the proximal tears and the proximal avulsions were the ones with where repair did really well in. There are, of course, those circumstances where the ACL completely ruptures and it's unavoidable that it needs to be taken out and it needs to be reconstructed with a tendon. And that is the case for some athletes. So what are our repair options? The first is bare. This is actually the one I got. There's also two things called ligamese and internal bracing, which we'll talk about briefly. And then stem cell is still very new. Regenix is really the only one doing it, and they are the ones doing their own research. So it is not recommended at this point. The studies are still very young. Traditionally, it's known that a torn ACL will not heal on its own. So when you tear your MCL, for instance, your MCL will form a clot and it will eventually heal on its own with some bracing and some rehab. Whereas the ACL, there's all the enzymes in the synovial fluid that are just rushing, and it's right in the middle of your knee joint. So with all the walking and bending, all of that all the fluid is just messing it up to the point where that ACL can't really form a good clot for repair. So the bare is a innovative technique that was invented in back in 2010, I believe, and was FDA approved in 2020, where they insert a cow-based, collagen-based, well, it's just a protein-based sponge that helps connect the two ends of your ACL. And there are still sutures involved and there are still tunnels, but they're extremely small compared to reconstruction. And the idea behind this is that ligaments heal with clotting and with a good environment. So if we can secure that environment for the ACL, similar to how the MCL heals, the theory is that your ACL should heal. There is certain criteria that needs to be met. You have to be older, 14 at least. And then you have to undergo surgery. It's FDA approved for 50 days, but the studies are actually shown for 30 days. So some surgeons won't do it unless it's 30 days. And it has to be one of these tears, so proximal avulsion to distal. And you can see here, and if it's distal avulsion, you're going to need a reconstruction. A primary repair is what we'll go into some more as well. And these are the clinical studies so far. So there's a lot going on this slide, but basically there's still ongoing studies. It's very new. And that was a lot of the pushback I got from when I discussed this with the original 3 surgeons that I talked to. But I ended up getting my surgery done at Duke with a surgeon who had already done 6 of these. And he was yeah, he had seen good results with this so far. So as you can see, there's not really long-term data right now. The longest we have is 2 years outcome, and those results look promising. It seems as if the people who had gotten Bear versus people who gotten reconstruction are on par in terms of their rehab and returning back to sports, and if not better, as in there is less pain and less strength, more stability reported. These are in process for 6 to 10 more years because there really needs to be more long-term studies on what it looks like down the line. And these 2 are still very new and they're still recruiting for. So this is what I said, about 86% of Bear patients return to pivoting sports in 1 year versus 70% of reconstruction patients. And the preclinical results looking at osteoarthritis in pork in pig models are very promising. They did see that the pig models who had the Bear done didn't have that ACL development versus the reconstruction subset. So this is really quickly internal bracing versus ligamese. And internal brace is just where they put in this metal rod to help connect your 2 ends. And then after a couple of months, they take it out. And that really just helps reinforce the connection. And ligamese is also similar. They use this big screw, which is very daunting looking, but that's only in for 6 months. They take it out and your bone heals on its own. You notice that these are both proximal and almost like proximal avulsion tears. So that's the only one type of tears is indicated for. This study came out and it compared those internal brace type repairs versus reconstruction. And the results were that it was significantly better for the repair for patients in terms of pain, returning to sport, and the rehab process. With the internal bracing, patients were already back to doing full-on rehab in like 1 month. They were already back to running versus 3 to 4 months in reconstruction. And some people were back to sports in 6 months, which is significantly quicker. And so this is also an ongoing study. They're still collecting more data, so more to come on that. So I wanted to put this quote up here from New York Times. Changes in medical practice can sometimes proceed at a glacial pace, maybe up to patients to pressure doctors to depart from accepted procedures. And basically, this is stating that making sure that your patient knows that they have choices and that they have a say in their decision-making process can go a really long way. I didn't know about repair at all when I initially went to talk to these 3 orthopedic surgeons. I was only offered reconstruction. And upon finding out more on my own, I was just very flabbergasted at how this was not something that was just simply brought up, you know. And of course, it takes a lot of time and there's a lot of pushback because, you know, we still need the long-term data before we can really be sure if this is the right move but something to keep in mind too is that we can let our patients know all that's out there and then the side effects and then have the patient have a little bit more power in deciding what they want to proceed with. So this is a little bit about ACL reconstruction rehab, and this is similar to Bear. So similar to the Bear rehab as well, except that in the first 2 months, it's really, really slow and it's kind of treated like a fracture. But otherwise, it's on par in terms of when to return to jogging. And this is all dictated a lot by your physical therapist. And there's also a return to sports criteria at that 9 to 10 months where they really look at your strength, your hop symmetry, your form, make sure that you're ready to get back into what competitive sport it is that the patient is playing. ACL injury prevention programs, this is from the AAFP, they have been shown to reduce injuries by around 50%. So a really good idea for our high school athletes and our college athletes. This is ACL Strong. It's an app where I think you have to pay for a subscription, but they also have Sports Metrics USA, which has their own prevention program that I think is available free of charge, but don't quote me on that. But these programs really focus on strengthening, stretching, safe maneuvers, and they're also sports specific. So why does prevention matter, and why does ACL tears? What else does it affect? More and more research is coming out that it can actually have a profound psychological effect on athletes, because the recovery is very long and lengthy and it takes you out for about 9 to 12 months. And a lot of these times, these athletes, their sense of identity is their sport. And having that taken away can be really difficult, as well as their confidence level returning to sports, and their belief and there's a lot of mental, I feel like, especially for me going back to PT, about simple things like going upstairs, using my right leg, a lot of mental block because there's just this fear of hurting it again. And also there's the risk that some competitive athletes won't be able to return after their surgery. So broad applications, Tommy John surgery is something that's typically used for our pitchers and baseball players when they tear their ulnar collateral ligament. Well, new studies have been coming out for primary repair of that. So the Tommy John usually uses reconstruction, so also with a tendon graft. But there's some really promising good research coming out for primary repair. Rotator cuff surgery is another one that traditionally uses repair first before they jump to something like total shoulder replacement. There's also some really emerging new research on possibly the ACL being able to heal on its own. That's being observed through MRI, and they're basically distributing patients on rehab versus no rehab and watching the MRI scans through there. But still very, very new and still needs long-term data to see what happens if someone with a full tear, chooses not to undergo surgery, but they do strict rehab. What their knee would look like 10 or 20 years down the line, whether osteoarthritis risk would be changed. So the big takeaway for my presentation is that ACL reconstruction is still the gold standard for now until ACL repair can have enough data and long-term data to prove it otherwise. So there's still a lot of studying that needs to be done, but for what we see now, it's very promising, and it's very important that we let patients know that there are other options when they have sports injuries like ligament tears or things, that it's not always just one size fits all reconstruction for everybody. I mean, this was an example of how much we don't even know about the ACL. There's still new research coming out. I don't think the two bundles were discovered until late 1900s. So there's still so much that we don't know about how our native ACL it can be important in healing and how we can preserve it, and therefore, not have to burn surgical bridges and increase our proprioception and increase our rehab protocol and overall down the line, in case someone does tear their native ACL, they still have the option to do a reconstruction. So these are my references, and I wanted to, before we get to questions, I just wanted to share that I actually found the Bear procedure through social media, and through there, I did my own research. And so we don't want to discount the power of what people can find online. There is misleading information, but this hashtag with Save the ACL has been going around regarding the internal brace technique that, especially with hospital special surgery, that was one of the top orthopedic hospitals in the country, where Dr. Felice is. That's where they do really a lot of the rehab, the repairs, and where patients fly in from all over the country to have that done. I did have a blog post that they did of my story on Duke's website. So I was very honored. So far in my rehab process has been going really well. Every day I'm so thankful that I got to keep my ACL with its with its native insertion points, and that I didn't have to get a graft and have to wait for the graft to heal and all of the mental implications that come along with that. And this picture here, this is Dr. Murray. So she is the one who actually invented the bear, and she's been researching this for decades. And back in 2020 was when it was FDA approved and when they started doing the studies. But I mean, it wasn't like it started anytime soon, like in 2020. It was like back in early 2000s when she first started looking at the MCL, looking at the self-healing of that, and kind of seeing if she could emulate that in an ACL. But that concludes my presentation. I wanted to see if anyone had any questions. Hope that wasn't too dense. And hope it was educational. All right, if there are no questions, I will turn it over to the next presentation. Let me stop sharing.